We are going to commence a session on glaucoma. First speaker is Dr. Shoaib Siddiqui, effect of glaucoma on binocular summation of visual acuity at low and high contrast. Dr. Shoaib Siddiqui. He's not there?
Absent? Is absent? He's absent.
I think he's absent.
Okay, then we'll call upon the next speaker, Dr. Sanchita Mehta. She will speak on efficacy of different doses of mitomycin C augmented needle revision in failing trabeculectomy blebs. Dr. Sanchita Mehta. She is also absent, I think. The next author, next presenter is Dr. Priyanka Siani. Dr. Priyanka Siani.
Doctors, the presenting author is Professor Dr. Sumit Sachdeva.
Presenting, yes. Presenting author is Professor Dr. Sumit.
Can you turn on the third presentation, please? No. The third one, Dr. Sumit Sachdeva. It's, my name was written in that. It was, I just checked, it was,
The chief author is written here, Dr. Priyanka Siani.
the presenting author is me.
Presenting author is Professor Dr. Sumit.
Yeah, so
Yes.
I'm the presenting author.
Yes, okay.
Yeah. So I would request you not to judge this as paper, because this was to be presented by the resident, but because they were not ratified members, so I had to present it.
Okay.
Right. Thank you so much, sir.
So, can we mark it or not?
I
Because
don't
there
think
are
so,
clear guidelines that those who are not ratified or not.
That's what I'm saying, because I am the presenting author. It was written as a presenting author. I can present, but I would request you not to mark it, because it is a PG session and I am the teacher for that.
Okay, okay.
Yeah. So,
Okay, so we will not mark it.
yeah, please, and don't mind my standing here amongst you all. And so my study, good afternoon everyone, and I hope everyone had a good lunch, and if not, then I'll not be keeping you for long. My topic is to study the RNF layer thickness in various grades of myopia. So as we all know that RNF is it's a crucial biomarker in the assessment of ocular health, and particularly in diseases such as glaucoma and myopia. As the entities sometimes overlap, so it is essential to study the RNFL thickness in various sectors to differentiate glaucomatous damage from the myopic damage. So this study was conducted in our institute, that is AIOS2025-Poster Rohtak, in which 208 eyes were analyzed, and patients were categorized into 4 groups according to the grades of myopia. Group 1 was mild myopia, less than 3 diopters, and 52 eyes were taken. Group 2, moderate, 54 eyes were taken, 3 to 6 diopters. Group 3, more than 6 diopters, and 52 eyes were taken. Group 4 was a control group in which the patients were, there were normal eyes, 50 eyes were taken in that. Exclusion criteria, all those cases in which the RNFL thickness is reduced, they were excluded, like glaucoma, diabetes, trauma, hazy corneas, because we cannot take a good scan on that, and other diseases, so we did not take that. Now, coming to the demographic profile, we know that majority of the patients were aged between 18 to 30 years of age, although we took from 18 to 50. There was no significant age or gender differentiation, and most of the participants were students, approximately 50%. Coming on to the observations, we came that axial length and myopia, we know that axial length correlated with myopia severity directly. High myopia group had 100% of the eyes with axial length more than 25 millimeters. Significant correlation between axial length and RNFL thinning was found. Fundus changes, as we all expect, higher degrees of myopia is associated with more fundus abnormalities. More than 50% of high myopia cases had moderate tessellations and peripapillary atrophy. There was a significant difference in fundus changes across all the groups. Now, the basic purpose of this study was to study the RNFL thickness. Now, RNFL thinning was most marked in superior nasal and inferior nasal sectors or the quadrants. Now, these are the quadrants in which superior and inferior, we have found that the thinning is there in glaucoma also. So we could, but they are more in supratemporal, infratemporal. Here it was supranasal, infranasal, and the least affected was the temporal lower quadrant. Higher myopia was linked with greater RNFL thinning, and every 1 millimeter of increase in size in axial length led to a thinning of average 3.87 microns. So as you can see in this picture, in this table, supranasal was the most commonly affected and most severely affected, and temporal lower quadrant was the least affected. Intraocular pressure was highest, surprisingly, in mild myopia group, which was mean was 13.31. Control group had the lowest, that was 11.52, and there was a significant difference between the groups. To summarize my study, the myopia severity affects the RNFL thickness, axial length, and the fundal changes. High myopia is associated with significant RNFL thinning. Supranasal and temporal lower quadrants are, supranasal is the most, had the maximum thinning, while temporal lower had the least thinning. Axial length and RNFL thickness have a strong inverse correlation, and further studies are needed to evaluate long-term effects. Now, the clinical implication of this is that optical coherence tomography must be interpreted with caution in high myopes, as false positive RNFL thinning can occur. Looking at the optic disc morphology, along with RNFL thickness and visual field correlation, helps to differentiate between myopic and the glaucomatous patients. And additional tests like GCC and intraocular pressure monitoring with visual field progression will help confirm the diagnosis. Thank you so much. Thank you.
The next presenter is Dr. Dodam Tarateki from Outcome of Pars Plana Aerolab Aqueous Drainage Implant in Vitreous Cavity in Neovascular Glaucoma.
Hello. Good afternoon, everyone. Our study is on Pars Plana placement of oral aqueous drainage implant in neovascular glaucoma in Indian eyes. So NVG is a severe form of secondary glaucoma with refractory IOP and poor visual prognosis in most of the cases. This study retrospectively evaluates the post-operative outcomes of RD implantation via Pars Plana, focusing on its effectiveness in IOP control and visual preservations. The aim of the study is to see the outcomes of Pars Plana placement of oral aqueous drainage implant in neovascular glaucoma. So a study was conducted in Arvind Eye Hospital, Tirunelveli, in the Department of Glaucoma and Retinal Services, in 28 eyes diagnosed with NVG with the Pars Plana placement of RD, and had a minimal follow-up 12 months. And a patient excluded were patient with less than 12 months and less than 18 years of age and monoocular patients. So the success criteria, we had two success criteria, one with IOP less than 18 mm of Hg or more than 5 mm of Hg or 30% reduction from baseline. And another one was less than 15% IOP or more than 5% of mm of Hg or 40% reduction of IOP without AGM. The qualified success was the same, but it was included with one AGM. So this is demographic and baseline clinical characteristic of the patients. So surgical procedures was done by both clinical glaucoma and retinal surgeons. So first of all, the glaucoma surgeon has done inferior nasal peritomy, and the plate, after isolating the muscles, the plate and creating the scleral tunnel of about 4 mm, the plate was fixed at around 10 mm away from the limbus, and then the rest of the procedures like inserting the tube into the vitreous cavity was done by the retinal surgeons. So as a result, out of 28 eyes, the mean IOP presented was preoperatively was 46.21, which was reduced to 19.64 in week 6, and till 12 months it was 22.67. And AGM reduced from 3 to 1.52 in 6 weeks and 1.752 in 12 months. So the BCVA was stabilized or improved in 54% of the eye in 2 months and 66% of the eyes at the end of the 12 months. So as for the criteria 1, the success rate achieved was 50% till 12 months, and qualified success was 83.3%. And as per second criteria, which was more stringent, was 37.5% in 12 months, and qualified success was 72.2%. So there was occurrence of at least 1% of adverse events like failure of external blood formation, hypema, loose sutures, subtotal hypema, RD, and tube occlusion in our studies. So, in our study, we got 50% reduction of IOP and 58.3% reduction of anti-glaucoma medication as compared to the other studies. And we had a complication rate of about 21.4% as compared to 30% and 65% as compared to the other studies. So the strength of our study was that this is the first study with the largest sample size assisting non-bulb RD implantation in pars plana, especially in diagnosed NVG case in Indian eyes. And the limitation is a retrospective nature and lack of control. So to conclude, our study saw that RD is safe and effective for pars plana implantation with vitrectomy in terms of controlling IOP and maintaining visual acuity in NVG cases. Thank you.
Good presentation. How does it work?
Sir?
How does it work?
Sir, basically, we did this study is because RD is presumed that it will start working after 6 weeks, and in NVG, most of the surgeons feels that this is contraindicated. But sir, we did this actually just wanted to see whether like in this NVG, because the visual deterioration are seen very fast. So just wanted to see that, but in our study we didn't get that, sir, actually.
No, I mean to say, how does it work?
What is the mechanism of
What is the
action of this?
mechanism of?
Oh, sir,
Action.
basically
How do they reduce the
it works as the same like the other. Basically, the ligation is done, and after the ligation opens up in 6 weeks, so we are expecting the IOP to be lowered, and that in our study we have seen that also. Like, sir, after doing the surgery, we'll keep the patient with some AGM until the ligation is open, and then after that.
No, I mean to say, what's the mechanism? What's the mechanism of action? How does it lower the IOP?
Oh, sir, that is how, first of all, after the ligation, there will be bleb encapsulations over the plate, and it takes time at least to this period when the tube opens. So it controls. In RD especially, there will be like fibrous ingrowth from the plate, and then it will anchor, and it will maintain that float. Basically, it is the fluid will flow from the ultimately from this blade area, it will flow into the subconjunctival space and into the
Epithelial
yes.
veins.
Okay.
What are the exclusion criteria?
Ma'am, exclusion criteria, we excluded patients who were monoocular, less than 18 years of age, and patients who didn't follow up for 12 months, sir.
And preoperatively gonioscopy was done, and there was any like patients with rubiosis iridis or something, or like some new vascularization in angle, anything that you have included, or you have excluded these?
Ma'am, it is there, but we have a protocol like first we will do the laser, then injection if possible, or sometime like during the intraoperative also we'll give the injection and do the surgery.
So after these various maneuvers, then you planned for this type of surgery?
Yes.
Okay, good. The next presenter is Dr. Trupti Patil. She will speak on focal disc damage, structural and OCT angiography of the optic disc and macular parameter correlation. Dr. Trupti is here? Okay.
Good afternoon, everyone. Today I am going to talk about the focal disc damage with hemifield loss, a structural and OCT angiography-based analysis of the optic disc and macula parameters and their correlation. So as we all know, OCT do help us to detect a focal change, be it a vascular or the structural change. We have earlier studies have shown that the vascular parameter do provide complementary information to structural change. But however, the benefit of vascular parameter over the structural parameter is still uncertain. So aim of our study was to evaluate the correlation between the optic disc and macula parameters based on structural analysis and vascular density analysis, and also to evaluate the diagnostic accuracy of the same. So we included the patients with primary glaucoma who has focal disc damage with single hemifield loss more than 18 years of age, and the focal disc loss was measured as focal rim thinning less than 4 clock hours. We excluded any patient who had poor scan quality, media opacities, or high refractive errors. So all patient underwent comprehensive eye examination, including the optic disc photograph, the OCT structural analysis, as well as vascular density measurement for both disc and macula, and visual field test. So we had total 103 eyes of 64 patients, out of which 75 had focal disc damage. So we divided them into four groups. Group 1, where the patient had focal disc damage with central visual field loss, were compared with those without the central visual field loss. While in second, we have group 3 and 4, where the group 3 patient who had unilateral disc notch and contralateral healthy disc were compared against each other. So when we for demographic details, the mean age of presentation was 56.7 years. Majority patients were phakic. The most common type of glaucoma was primary open angle glaucoma, and the most common location of damage was inferior. So when we compare the structural parameter of the optic disc and macula, what we noted that the average the retinal nerve fiber thickness was significantly different between the notch versus no notch. Similarly, the vascular density parameter were also different only between the notch versus no notch group. While in case of macular thickness parameter, they were found to be different between both the group, and visual fields parameters were different between all the four groups. So when we analyze other parameters for disc and macula, for the optic disc parameter, what we noted that the average rim area, average vertical CD ratio, and average inferior density perfusion was definitely different between both the groups. And among macular parameters, only inferior quadrant thickness and average GCL IPL thickness and minimum GCL IPL thickness was found to be different between both the groups. So when we studied the correlation between the optic disc and macula parameter, the structural parameter definitely shows substantial correlation, while vascular density parameter showed weak correlation. When we assess the strength of association, it was definitely better for the structural parameters, and it was weak for the density parameters. And the area under the curve was definitely better for the structural parameter as compared to angiography based parameter. So when we have a patient with focal disc damage, yes, we do get changes based on structural parameter as well as angiography based parameter. However, the correlation between the optic disc and macula structural parameter definitely shows stronger correlation. The strength of association is stronger, and the diagnostic accuracy is also definitely better as compared to angiography based parameter. And Rabilo et al. Have analyzed similar results, and they had attributed it maybe because of the different vascularization of the optic disc and macula. So to conclude, compared to angiography parameters, definitely the structural parameters has better correlation, highlighting the importance of structural OCT in the era of angiography based OCT. Thank you.
Excellent presentation. So do you think that structural abnormalities are more important than the angiographic pattern?
Yes, I do, sir.
So thank you very
Thank
much.
you.
Next presenter is Dr. Prashant Kumar Athota. He is presenting on the Pittsburgh Sleep Quality Index in glaucoma patients.
Good afternoon, everyone. I am presenting about Pittsburgh Sleep Quality Index in glaucoma patients. So, sleep plays a very important role in physical well-being, mental well-being of everyone, and the sleep was mainly controlled by circadian rhythm in the humans. So there is a scientific basis for sleep in glaucoma patients. We all know that glaucoma is mainly caused by ganglion cell death. So there are a subset of ganglion cells called intrinsically photosensitive retinal ganglion cells. These cells secrete melanopsin, and this melanopsin plays a role in circadian rhythm and modulation of the melatonin secretion. So we did a study to assess the quality of sleep in glaucoma patients. So this is a cross-sectional study involving the glaucoma patients who are visiting to our hospital. So all the glaucoma patients have characteristic optic disc and visual field changes. They are they are coming to the hospital for the first time. So patients with any known ocular and systemic diseases causing sleep disturbance were excluded from the study. The 7 components of the Pittsburgh Sleep Quality Index were compared with the normal group. So this is the sleep quality index questionnaire. So these are the 7 sleep qualities which were assessed by using this questionnaire. They are subjective sleep quality, sleep latency, sleep duration, habitual sleep efficiency, sleep disturbances, use of sleeping medication, daytime dysfunction. So we included 34 glaucoma patients and 34 agent sex matched controls. So this is the demographic data of these individuals. So in our study, these 4 parameters were found to be comparatively statistically significant between the two groups: sleep latency, sleep duration, habitual sleep efficiency, and daytime dysfunction. So I will enumerate all these 4 parameters. So sleep latency is mainly the time taken to go to sleep from the time of going to bed. So the grades indicates the severity. Grade 2 is more severe. So if you see the grade 2, the 6.7% of glaucoma patients were affected, where none of the patients were affected in the normal group, and the correlation was statistically significant. So sleep duration, if you see the grade 3, which suggests more severe effect of sleep duration, so that is less than 5 hours of sleep. So in normal group only one individual was included, but in glaucoma there are 11 people. So habitual sleep efficiency, this is calculated by number of hours slept by number of hours spent in the bed into 100. So coming to the table, the grade 3 is more severely affected sleep efficiency. So 35 in the glaucoma group was affected compared to the 12 people in the normal group. So in the daytime dysfunction, so five people in the glaucoma group were affected, whereas none of them in the normal group had any discomfort. So and all these things are statistically significant. So conclusion is these 4 parameters were statistically significantly different between the normal people and the glaucoma affected people. So take home messages: along with the control of intraocular pressure, we need to consider into the quality of sleep and quality of life while designing our treatment plans for the patient. So that will help them to improve their quality of life. Thank you.
So, and what other significance you can think of, like about the duration and the time of the eye drops or medications they should take?
Yeah,
that
the
should also
treatment
be
plans, whether we are doing medical treatment or surgical treatment, has to be decided mainly on the quality of life of
quality
the
of life, the duration of time. The people who are working in the night time,
Yes.
their duration of sleep is affected. Their sleep cycle is affected. So accordingly, the treatment, anti-glaucoma medications should also be customized from patient to patient. It should not be just a rule that it's a twice a day or it's a 12-hourly dosage.
Yes.
Then we have to think at what particular time that patient has to take it, which will be useful. So we must know the graph of the time when the effect of the medication starts and when it is least. So we have to be more customized in our management of glaucoma patients.
Yes, ma'am.
So it's a good consideration. And another thing is that patients, though you have excluded the patients with systemic diseases, but then it has been considered that nocturnal hypertension is also affecting things.
Yes, ma'am. There are many confounding factors in the study. So whoever the patients known to be having disorders affecting their sleep quality were completely excluded from the study. So only the patients with the pure glaucoma with the characteristic field and optic disc changes were included. Any other systemic disease and ocular disease were excluded.
Right.
I have a question whether the class of drug was affecting the sleep quality.
Sorry, sir, could you please repeat?
I mean to say, have you assessed different class of drugs we are using in glaucoma?
No,
Their
sir.
association with the
No, sir. To include in this study, we excluded the patients who are using brimonidine basically.
okay, you
So,
excluded them.
We excluded brimonidine patients who are using it, and we didn't see any thing like using brimonidine patients and didn't use brimonidine patients. We are continuously doing this study, so on the way we are going to assess it whether any daytime dysfunction between brimonidine users and non-brimonidine users.
Why you have excluded brimonidine?
Brimonidine was known to be causing daytime dysfunction and it was causing daytime sleepiness. So we keeping that will be affect the study. We excluded the
Because
brimonidine.
that's why the brimonidine is not recommended during the daytime to be
Yes.
portrayed. Thank you very much. Please. Please.
Mainly primary glaucomas, madam. Either both. We didn't look into different.
Consider.
Yes, ma'am. Yes, ma'am. We didn't look into that part. We recently collected data. We are interpreting. We will go into that.
This
That
should
has to be
included.
assessed, ma'am.
This should be included and should be categorized according. Like you have to take in a study, you have to take one type of like only primary open angle glaucomas, then the another study for only primary angle closure glaucoma. So that will be better if we, because totally the pathogenesis is totally different in each of them.
Yes, ma'am.
So we have to consider that also in our study.
Thank you very much.
Thank you.
The next presenter is Dr. Ravindra T. He will speak on to create a guide for the corrected disc sizes with varying biometric functions and a unified DDIS and CDR scale.
Good
Your
afternoon, sir.
present-
Good afternoon, madam. Thank you for the opportunity. No financial disclosures. Actually, we all know that glaucoma by definition is an optic neuropathy with typical alterations. And one of the most important factors with respect to glaucoma diagnosis is the need for generating the probabilities about the future with our human intelligence, that whether it is going to progress or not and what is the rate of progression. But here today we are focusing on the basics, like disc size is an important aspect, and CDR or inferior and superior rim ratios, which are both critical or sometimes very difficult assessments. As we see, we have got the disc damage likelihood scale, where we have got the disc sizes and the corresponding templates being given to us, but somehow we find that there is a need for further improvement in the disc templates, and that has been our effort, so that we can grade the discs as per the low risk, moderate risk or high risk at an early stage of the documentation. So here we are taking the 1 millimeter spot size that is photographed alongside the disc, and whether it is equal to 1 millimeter or 1.6 millimeter. Like that, we will be making the use of nomograms for getting the actual value of the disc, and then after the disc size, whether the symmetry or asymmetry is there, and then whether the refractive status is on side of myopia or hypermetropia, so that the corrected disc size and the correct unified corrected DDLS CDR scale could be available for us. So here we find the difficulties with measuring the disc size being demonstrated. Most of the slit lamps don't have these facilities, and even if they are having a facility, it is not easily viewable, and therefore we came up with our own innovation and the templates using the 1 millimeter spot size of the slit lamps. So the relative size is seen, and then we are able to do the estimates. So here, whether the disc corrected size, actual estimated size based on the lens we are using and the correction factor applied, these templates will be there, and we get the disc size. Once the disc size in millimeters is given to us, then we have to make the assessment related to asymmetry or symmetry. So earlier on, the templates that were given by the DDLS scale are present at disparate points, but here we have brought the numbers related to the risk very close to the templates. The template is having the grade of the DDLS mentioned here itself, very close to it, and the correction factor, whether it is because of the disc size or because of the myopia or hypermetropia, can then be calculated, can then be read up with the help of these templates. So if it is myopia, we go to a lower risk. If it is hypermetropia, we go to a higher risk. So we don't have to actually go for all the templates, but whichever is close and similar, that is what we will use. So here if it is a myopia, if it is the small disc and this is the appearance, then we will read it as 4. And if it is large disc, we will read the score as 2. And if it is actually within the normal accepted range, like not more than 3 diopters myopia or 3 diopters hypermetropia, then we can take the scale as 3. And similarly, we can do the corrections with respect to hypermetropia and emmetropia, hypermetropia or myopia. But the key takeaway is that it is very important to be able to assess the disc size, and the tools that are available are very difficult to apply, and ultimately probably the machine learning tools and AI tools are required in this stage, in this area, and then we will be able to minimize the observer variations and improve the diagnostics, and then the treatment outcomes. Thank you.
Nice presentation. But what is how much is the clinical applicability of such tools?
Yes, sir. This is just in the concept stage, and clinical applicability is difficult. That is why the final stage is that slide is saying that we have to wait for the real automation with respect to this. We will be requiring the photograph and the parameters related to hypermetropia or myopia, those refractive status coming in.
Ultimately, any research has, we have to see the clinical applicability.
Yes. Yes.
So whether the this study will help in the clinical applicability, that's whether it can be used in routine OPDs.
Yes. Yes.
I don't think with the variation and with the different tools needed for this, the availability and the applicability will be possible in the setup where we have the infrastructure set up in India.
The 1 millimeter spots slit lamp is available in most of the slit lamps. Okay. And in some of the JAI slit lamps it will be 0.5 or 2 millimeter. So the nomograms will be required for the slit lamp that we are having. The reference diagrams will have to be customized. So we have got the Topcon SL1E slit lamp where there is a 1 millimeter spot size. And in the JAI slit lamp we are having a 0.5 millimeter and then the 2. But in the Topcon SL1E slit lamp we have got the 1 millimeter spot size. And whenever the patient is having myopia, then we are finding that it is very small, this comparison in comparison to the disc appearance. Then we will say if it is 1.6 and the correction factor is 1.3 for the lens that we are using. So 1.6 into 1.3 and we get the correct size. So it becomes more than 2.8. And what the machine learning algorithms or AI algorithms will ultimately do is to read these things automatically.
So generally we use 90D or 70D for the examination. What is the correction factor in these two lenses?
In 90D we have got 1.4 for most of the models, and it is 1.1 for the 78D or 60D.
Okay, thank you very much.
Yeah.
The next presenter is Dr. Sumit Goyal. He will speak on quantification of anterior chamber angle in North Indian population using serous tomographer. Present? No. So the next presenter is Dr. Seema Meena. He will speak on the qualitative and quantitative evaluation of corneal endothelium in patients of primary glaucoma. Present? No. The next presenter is Dr. Namrata Shri. She will speak on prevalence of primary angle closure disease, assessment with Von Herrick test, gonioscopy, and anterior segment OCT.
Good afternoon, judges and everyone present here. I am going to talk about prevalence of primary angle closure disease, assessment with Van Herrick test, gonioscopy, and AIOS2025-Poster. Glaucoma, as we all know, is a group of chronic progressive multifactorial optic neuropathies in which intraocular pressure, among other contributing factors, are responsible for a characteristic acquired loss of retinal ganglion cell axons, leading to atrophy of the optic nerve with demonstrable visual field defects. Open angle and angle closure are two types. High prevalence of occludable angles and primary angle closure glaucoma in people of East Asian descent suggests that assessment of drainage angle should be considered for all adult Asians attending OPD. Gonioscopy is the gold standard. The Schoffer system grades the angle on how much of the angle is open in terms of geometric measurement in degrees of the angle formed between the insertion of iris into the wall of the eye and the trabecular meshwork. Estimation of peripheral angle chamber depth by a 4-point grading scheme given by Van Herrick is a non-invasive alternative to gonioscopy and gives comparable results. AIOS2025 based on low coherence interferometry with a superluminescent diode have a wavelength of 1310 nanometer allows a deeper penetration and cross-sectional imaging of the anterior chamber and visualization of the angle. This was an analytical cross-sectional study performed over a period of 6 months in a tertiary eyes hospital in northeast India. A total of 200 eyes of 100 random patients who presented in OPD were included. The inclusion criteria were consecutive patients coming to OPD between 40 to 80 years of age of either gender with spherical refraction between -3 to +3 diopter. We excluded the patient less than 40 years or more than 80 years of age or having a prior laser or intraocular surgery or any history of prior ocular trauma, mature hypermature cataract or severe corneal pathology which may interfere with the gonioscopy, dilated pupil due to any cause, and refractive errors more than 3 diopter. The sample population included left eye 100 and right eye 100, a total of 60% male and 40% female population. In Van Herrick, we found 20 angle were closed and 180 eyes have open angle. In AIOS2025, 8 eyes had closed angle and 192 eyes had open angle. In gonioscopy, we found closed angle on 8 eyes and 192 eyes had open angle. In AIOS2025, we found 7 eyes with closed angle and 193 eyes with open angle. Comparing Van Herrick's with gonioscopy, out of 20 closed angles, we found 12 eyes with open angle and 8 eyes with closed angle. And out of 180, all were having open angle. This gave the sensitivity of 100%, specificity of 93.75%, positive predictive value of 40% and negative predictive value of 100%, giving a diagnostic accuracy of 94%. Comparing AIOS2025 with gonioscopy, we found out of 7 eyes having closed angle, 3 were having open angle on gonioscopy, and out of 193 having open angle, 4 were having closed angle on gonioscopy. It gave the sensitivity of 50%, specificity of 98.4%, positive predictive value of 57.1%, negative predictive value of 97.9%, and diagnostic accuracy of 96.5%. We did a cross tabulation in which 20 eyes having open angle, 20 eyes having closed angle in Van Herrick, we found 15 were open on AIOS2025, and out of the 180 open angle on Van Herrick, we found 2 were closed on AIOS2025. Gonioscopy is considered as the gold standard, as we all know. Sensitivity and specificity values of Van Herrick with gonioscopy as reference was 100% and 93.75%, vindicating its value as a good screening test. Negative predictive value of 100% indicates that Van Herrick grading can be useful in ruling out case of angle closure with accuracy. Similar results were found by the study done by Foster PJ et al. A high specificity value indicates AIOS2025 could be used as a confirmatory test. Similar results were found by Radhakrishnan et al. So we conclude saying that angle closure glaucoma is a sight-threatening condition that can result in profound visual loss In the early stages and in predisposed eye, the disease is curable by a non-invasive laser iridotomy. Thus, early detection and treatment is really important. The Van Herrick method, because of its high sensitivity and high negative predictive value, can be used as a screening tool. AIOS2025, on the other hand, can be used as a confirmatory measure. Gonioscopy is mandatory tool in evaluation of anterior chamber angle assessment, and none of the above mentioned can replace it. Thank you.
These are all well recognized clinically assessment for the anterior chamber angle.
Yes.
What new was in your study? What was new in this study?
So it is just to emphasize the role of gonioscopy and not to replace it with any other method of assessment of the angle of the anterior chamber.
So suppose anterior segment OCT does not have a dynamic contour.
Yes.
So gonioscopy is better than anterior segment OCT in detecting.
Yes, sir.
So what message does it tell ultimately for the take-home message?
So take-home message is that if we have to do screening on a huge population, we can go for Van Herrick methods that takes less time, and for diagnostic measures we can use AIOS2025, but ultimately if the patients are diagnosed with glaucoma, we should go for gonioscopy in each and every one.
I think you should put it like this, that in a big country with big population of India, where all the instruments are sometimes not available in the remote areas, the basic foundational methods of our glaucoma assessment are equally good. Secondly, gonioscopy is mandatory not only to assess the angle but also to find the reason sometimes. Like we may find that there may be some posterior synechiae, or there may be some there may be new vascularization or something. So we must always do gonioscopy in each and every patient, which is not nicely possible with AIOS2025. I would say that will be better then. So total dependence on the new technology should not be there. Clinical acumen is equally important, and of course clinical acumen is available at remote areas also. So that's should be considered. That may be the additional part of your message.
Thank you.
Thank you very much. So the next presenter is now Dr. Pavitra Panarsilvam. She will speak on 3D visualization of visual field, enhancing understanding with the hill of vision.
Good afternoon everyone. I am here to talk on the 3D visualization of the visual fields, enhancing its understanding in the hill of vision. So practical sessions facilitates teaching, critical thinking and coping skills, especially among the ophthalmic neophytes. We have printed complex 3D models pertaining to ophthalmology, such as circle of Willis, cerebral venous system, eyeball models, to facilitate the learning among the ophthalmic neophytes residents through the tactile 3D puzzle assembly. So to further enhance the understanding of hill of vision, we made a 3D model out of it, which helps in easy understanding of the complex visual field defect. So these models offer a detailed visualization of the visual fields, providing an invaluable insight for the doctors and the students. 3D models provide doctors with a clear visual representation of the patient's visual fields to improve their communication with their patients. For students, these models serve as an educational tool, making a complex concepts more easily accessible and comprehensible. So basically, visual field is the island of vision in the sea of darkness. It's a three-dimensional graphical representation of the differential light sensitivity at different position in the space. So we consider eye as a cone. Here we consider it as a cone, and in that cone, while viewing from the topmost portion, we can see the 2D representation of a 3D cone. So we visualize the same with the visual field here. This is the superior portion is a 3D representation, and from the top view we can see the 2D representation of the 3D visual field. So we started this with the drawing the visual hill of vision, where the x and the y axis will represent the spatial extent of the visual field using the radial coordinates, and the Z axis will represent the sensitivity to the light. So we initially started with the sensitivity threshold at one particular location, and we go about the different location, and finally we found the sensitivity threshold at all the locations, and we drew the hill of vision. So this is how a normal hill of vision represents. For a normal eye in a typical daylight illumination, the sensitivity is highest in the central area and decreases gradually towards the periphery. So we used a software named Maya LT software to create this 3D model, and following it you use a Cura software which is a slicing software to print these 3D models in sliced layers. So this Cura will give the output in the form of SLT, which is standard tessellation language, which is needed for the 3D printing. After which we used a material named the polylactic acid, which is biodegradable plastic manufactured from cornstarch, cassava and the sugarcane waste. So here is how the 3D model is being created. From a sphere we made it as a dome, and later we make it as an hill of vision, constructing the superior and the inferior field. So this is how the 3D hill of vision is made. So these are the steps, and this is how a normal hill of vision looks. So here we have the model here, which is the final output of what we have created. This is a normal visual field where the center portion will have the highest light sensitivity, and it decreases gradually towards the periphery. So similarly, we made a pathological hill of vision as well, which shows the abnormal light sensitivity altered and in a altered hill of vision. Similarly, we created in the 3D model from a normal hill of vision, we created scotomas, visual field defects, and this is how an arcuate scotoma looks like. So we have a defect which shows the scotoma here, and this is the real-time video of what we have created. We have the model here. This is representing the superior arcuate scotoma, and we also have a quadranopia which shows the portion of what a superior quadrant is being defective, and we also have an isopter contraction which shows the universal decrease in the light sensitivity. So this is how we created all the models out of the 3D printing, and this is showing the prototypes of the model which we have made till now. We also made a 3D model of circle of Willis. This is how the final model looks, and the cerebral venous thrombo and the dural sinuses. We also have a model of a 3D model of eyeball, which segregates each and every layer for the better understanding of the neophytes. So finally concluding, 3D printing is perfectly suited for creating complex 3D puzzles in a cost-effective manner, making it ideal for the rapid prototyping. So 3D visualization deepens our understanding of visual field, illustrating how sensitivity of light changes across different areas. This innovative approach not only aids in education and diagnosis, but it also contributes to the better patient understanding and the treatment of the visual disorders. Thank you.
Very good presentation, nice content. What is it more effective for education or for clinical management of the patient?
Sir, it's useful for both, sir. First, initially for the patient understanding, to make them know about the importance of glaucoma, we can have a good patient-doctor relationship, sir, so that they can understand how glaucoma causes this scotoma. So we can enhance their medical compliances, and in case of students, those don't have that idea of how the visual field looks, so this will have a better understanding, helps them to understand better what the visual field looks and how each stage of glaucoma is being proceeded. So we made it as a prototype model. We are just making other visual field defect model also.
Can it be used and this can be applied for diagnostic purposes? Like can we assess it in each and every patient, like we get a model on the computer screen with the according to the threshold sensitivity the patient clears?
Yes, ma'am.
And then we can make it like this?
Yes, ma'am. Yes, ma'am. We can do that.
But
okay, thank you very much.
Ma'am, this is a prototype model we have made now. It's about 500 rupees each model. When we made it as a bulk manufacturing, maybe the cost can be reduced as. Ma'am, it takes around 4 hours for a model to be printed.
initially you will make it on the screen? like for that?
Yes, ma'am. We'll make it in the software, and
Software,
from the
and then
software we are printing it as
printing
models.
it out in the form it is.
Okay, thank you very much. The next presenter is Dr. Rachna. She will speak on a role of color Doppler in the diagnosis of glaucoma in CKD patients. She is present? No.
Good afternoon, everyone. I'll be talking about role of orbital arterial color Doppler now. There are no financial supports and sponsorships. Introduction. Glaucoma is a neurodegenerative disease marked by the loss of retinal ganglion cells leading to damage of the optic nerve. While elevated intraocular pressure is a primary and most studied risk factor, glaucoma is multifactorial. Other contributing factors include the vascular dysregulation, reduced axoplasmic flow and oxidative stress, along with genetic predisposition. In recent advancements in diagnostic techniques such as color Doppler imaging have revealed that glaucoma patients have exhibited reduced ocular blood flow velocities compared to individuals without the disease. My aim was to analyze difference in orbital blood flow measured by color Doppler imaging in chronic kidney disease patients with and without glaucoma, to correlate between the RNFL thickness and color Doppler imaging findings in each group. It's a cross-sectional hospital-based study conducted between November to January. My inclusion criteria was patients diagnosed with CKD stages 1 to 5, aged 18 and older. Patients must be in a stable condition with no recent changes in medications that may affect the renal and ocular blood flow. Exclusion criteria were patients who have undergone glaucoma surgery within the last 6 months with significant ocular diseases, uveitis that may confound the Doppler results, acute kidney injury or rapidly progressing renal failure, systemic conditions that are diabetes, uncontrolled hypertension, severe cardiovascular diseases, non-compliant with study procedures. These patients have underwent a detailed vision evaluation, IOP, gonioscopy, fundoscopy. Optic nerve head assessments were done and were categorized them into glaucomatous group A and non-glaucomatous group B. Patients underwent color Doppler imaging studies of ophthalmic artery, central retinal artery and posterior ciliary arteries. Orbital blood flow was measured by evaluating the parameters like resistivity index, peak systolic velocity and end diastolic velocity. These findings were correlated with fundoscopy findings. SDOCT was done to obtain the retinal nerve fiber thickness to compare it with the color Doppler imaging findings. This is a fundus photo and RNFL thickness of a patient. Here my results were differences in the orbital blood flow between CKD patients with and without glaucoma. The cases with glaucoma have significantly lower PSV and EDV in ophthalmic artery, central retinal artery and PCA, suggesting that there is compromised orbital blood flow. The resistivity index differences are less significant, but there is a trend observed that there is reduced resistivity index in cases with glaucoma. These are few images of color Doppler imaging in cases of glaucoma. The optic nerve head and intraocular pressure differences, it is seen that IOP is significantly higher in CKD with glaucoma patients, supporting that there is an increased risk for glaucomatous progression. The CDR ratio is larger in the glaucoma group, reflecting optic nerve damage. Coming to RNFL thickness and comparison of CDI parameters, there is a significant positive correlation between RNFL and the peak systolic velocity and EDV velocity values in all the three arteries measured, which suggests that higher blood flow is linked to better optic nerve health. The resistivity index has a weak inverse relation, indicating that higher resistance could contribute to RNFL thinning. Here it summarizes that it shows a difference in intraocular pressure, cup disc ratio and orbital velocity, along with kidney function markers, that is serum creatinine and GFR and hemoglobin levels in cases of CKD with and without glaucoma. There is a significant rise in IOP. Coming to discussion, color Doppler imaging is a non-invasive tool for assessing ocular blood flow, particularly in systemic diseases like CKD. Our study demonstrated that there is a significant alterations in ocular hemodynamics in CKD patients, which is characterized by increased resistivity index and decreased end diastolic velocity in ophthalmic and central retinal arteries. These findings suggest that there is an increased vascular resistance and reduced perfusion, likely due to endothelial dysfunction, atherosclerosis and systemic hypertension, which is commonly seen in CKD. The notable findings of this study are progressive reduction in peak systolic velocity is seen in advanced CKD diseases, CKD stages. Optic nerve hypoxia and retinal ischemia is seen, which may potentially contribute to further complications. The ocular complications such as hypertensive and diabetic retinopathy, ischemic optic neuropathy and glaucoma-like changes. Here, there is a comparison between previously done studies and our study. In our study, we've seen that resistivity index, there is an increased resistivity index in ophthalmic artery and central retinal artery, which is already proven in previously done studies. But there's a difference that the primary pathophysiology, there's a same correlation that the primary pathophysiology could be systemic vacuolar compromise affecting ocular blood flow. And in a previously done study, it's ocular nerve hyperperfusion deficit and vascular dysregulation. I would like to conclude that color Doppler imaging shows that CKD causes reduced blood flow and increased resistance in eye vessels, raising the risk of optic nerve and retinal damage. These changes are similar to those seen in glaucoma. Color Doppler imaging could help detect eye complications early, highlighting the importance of managing blood pressure and circulation to protect vision in CKD patients. The limitations of the study were that it's a small sample size and the inter-observer variability between color Doppler imaging varies. These are my references. Thank you.
Thank you very much. Very excellent idea. But the color Doppler availability in our OPDs is very less.
Yes, sir.
So what's its clinical implications?
We have taken in an established setup where we have
otherwise
patients.
the idea is very nice.
Ideally,
The idea
it is
is
not
very
an
nice,
OPD
but
procedure.
what is the availability and the clinical correlation and clinical application of this?
So maybe if we study more in detail, we can have a setup and we can refer patient for color Doppler imaging. Like both CKD and glaucoma have this micro.
You had availability of this color Doppler in your OPD?
Not OPD, sir. Ours is the medical college.
Okay.
I am a postgraduate.
Okay.
So in the medical college, associated with the radiology
That's
department.
Right. Color Doppler is with the radiology department.
Radiology department.
Radiology.
Sir. Radiology.
Okay.
Yes.
That's with the radiology department.
Yes, sir.
Okay. You have any questions?
It's okay. It's a non-invasive procedure, but of course, it's not that approachable for
yes,
every
the microvascular
centers and remote areas. It's only in the institutional areas or multi-speciality institutes that there is availability of color Doppler, and at that place also it is quite not so common everywhere. Secondly is the cost efficiency.
Yes.
It is quite a expensive procedure which may not be approachable for every person.
Yes.
So in that case, clinical acumen is the only thing which can be considered, of course. But of course, it's a nice, good idea. We must go ahead with this.
It was a very innovative idea and very excellent presentation.
Thank you, sir.
All the best.
Ocular blood flow, relationship of ocular blood flow with glaucoma and optic nerve ischemic changes is quite a burning issue.
Yes.
And it should be extensively studied. So one of the good tool it is. It should be studied. It's okay.
Thank you.
Fine. Next presenter is Dr. Pradeep Balam. On effect of glaucoma medication on lipid layer thickness in patients with newly diagnosed glaucoma. Dr. Pradeep. Is not available? Okay. Then we have to conclude the session.
One more is there or not?
I think he's the only last person.
Okay.
So we'll conclude the session. It's a nice discussion. Any more questions? Anybody have any more discussions? I think we should have a photograph of the whole team.
Yes, exactly.
Let us have a photograph. All the speakers, please come on the stage.